Q&A function. And then after the talk, we will have a Q&A session. Also, Jessica has some news that she wants to share in terms of Zoom links for the student discussion, as well as T32 link as well. So look for that in the chat function. So today we have Morgan Philbin, who is an assistant professor in the Department of Socio-Medical Sciences at the Columbia University Mailman School of Public Health. Dr. Philbin's research focuses on community-based and social determinants of health. She's interested in how public policies and clinical practices shape inclusion and health equity for racial, sexual, and gender minorities. And she's going to be talking to us today on mixed methods analysis on her research topic called state-level immigration and immigration-focused policies as drivers of health disparities among Latinx individuals in the U.S. So Morgan, I'll let you take it away.
Awesome. Thank you so much for that introduction. And let me share my slides. And then, all right, can you see the regular slides?
Yeah.
Okay, so if I go through, it's all good. Perfect. All right, so thanks so much for all of you for coming today. And as Peter mentioned, I'm going to be talking about state-level immigration policies and health disparities with a focus on Latinx individuals. And I'm going to be talking about both quantitative and qualitative work that I've done. And I want to thank Peter and Sarah for inviting me, and to Gianna for helping organize this and for giving me the opportunity to share my work with you. And also to all of you for coming, since I know we're super sick of Zoom and it's a Friday afternoon. So I'm really excited to hear your thoughts during the question and answer period. And I also want to note that I'm going to start off talking about this line of research more generally and explaining how we created some of these policy measures. And then I'm going to give an example for work that I'm in the middle of doing. So it is brand new. We're still playing around with the analyses, and I decided to do work, to present work that wasn't finalized, because I wanted to use this as a way to get your feedback on things, to show kind of behind the scenes how we're thinking about the policy climate measurements more broadly. So again, this definitely are things that we've been working up just in the last couple of weeks. So yeah, we would love any suggestions you have, and I'll particularly flag some moments and things we'd love your thoughts on. So why social policies? Why am I looking at this? So as we know, social policies regulate nearly all aspects of our lives. So thinking about where we work, how we get there, the physical climate, access to healthcare, things like that. And much of public health research tends to focus on individual level factors. And while those are obviously incredibly important, we also need to think about the broader climate within which these behaviors occur, and then work to enact policies that make health promoting behaviors the default. And policies are also important because they serve as symbolic markers of who's allowed to inhabit a given space, access a service, or become a full member of society. So immigration policies, like I'll speak about today, marriage equality is another example. And policies are also differentially implemented and enforced in ways that can convey that sentiment. So thinking not just about the passage of them, but who they might be enforced toward. And for example, substance use policies are a really good example of that, and differential enforcement with Black or Latinx youth. So I know I'm probably preaching to the choir on this one, but I briefly wanted to note that one of the other main reasons we look at social policies is because they have such a direct and large scale impact on the public's health, much more so than changes at the individual level. And state and local policies can also counteract exclusionary federal policies. And we've seen this with immigration. And then depending what happens this summer with the Supreme Court, Roe v. Wade is also another example of this. And then lastly, and most importantly, I think policies are conceivably modifiable through sustained and organized collective action. And so this highlights the need to both create an evidence base to show which policies to target, and also to collaborate, with advocates, key stakeholders, and policymakers to support the adoption of policies that directly improve daily life for individuals and communities. So I'm going to quickly highlight some common approaches to policy research in order to show how the approach I'll discuss today is helping to try to address some of these challenges and to push the field forward. So first, policy research often takes a relatively narrow definition of what constitutes a structural driver or policy. However, my work and that of others has increasingly incorporated other structural drivers, such as attitudes, clinical guidelines, and political determinants of health and funding streams. Second, much of the current policy research, particularly in public health, uses binary exposure measures, so meaning whether or not a policy was passed. But this approach often fails to capture nuanced variation around policy details. So, for example, in my work with substance use, whether medical cannabis laws allow for home cultivation, or as I'll talk about today, driver's licenses, not just whether or not they're allowed for undocumented individuals, but whether they look like a driver's license that somebody who is documented might have, who is a US citizen. Third, policy research often focuses on whether there is a relationship between policy and an outcome, as opposed to exploring the mechanisms through which this association occurs. And this often requires the integration of qualitative methods. And that's also particularly important because it can highlight not only what the mechanisms are, but also what the levers are, so we know where to intervene to maximize health equity. And then lastly, much of the current policy research takes a sort of one policy, one outcome approach. So thinking about, again, how cannabis policies might affect cannabis use, or how a health insurance policy may affect care engagement for individuals who are undocumented. And while important, this often fails to capture two things. So first, policies often have unintended or spillover effects and can influence outcomes not directly targeted by that policy. And second, this approach also fails to capture the fact that the policy climate into which that single policy is passed can vary substantially from state to state, or that other policies may be simultaneously affecting the same outcome. So taking a policy climate approach may help explain some of the discrepancies we're seeing in results in existing policy research. So I want to first define what I mean when I say policy climate. So I'm referring to a composite measure of structural drivers. So this can include policies, but also funding streams, attitudes, political determinants, for example, and then having that serve as a single exposure, a singular exposure. And so this novel approach to policy measurement can help us understand the broader climate within which individuals live and how that shapes their health. And so I'm going to walk you through that process right now of how we came up with that for immigration policies. So in this section, I'm going to describe work I've led on immigration policy climate research, starting with a conceptual paper that I worked on, and then moving towards some qualitative work and then some quantitative data. So briefly, why immigration policies? Why am I focusing on this? Why does it matter? And so first, I began working on immigration policies because of a longstanding interest in migrant farm worker health. So I grew up in an agricultural region of California, and I'm actually back here now. I'm a visiting scholar for the year at Berkeley. And so it's been really nice. I mean, both to be home and closer to family, but also to be able to do more of this work on the ground. And simultaneously with that interest, research at the time had begun to suggest how immigration policies could affect health more directly. And I wanted to examine that in more detail. And then also, as shown in the figure, you can see that just the sheer volume of policies over time, this figure is just from 2009 to 2019, and also how many exclusionary policies. So you see exclusionary in gray. Just the volume of how many there were made me really realize the need to conduct this work. And then also, like I mentioned, because these policies can be modifiable. So for example, there are now 17 states that allow undocumented immigrants access to a driver's license. So we started this project with a conceptual paper to really help us think through the pathways through which immigration policies might affect Latinx health. So for this paper, we first identified the landscape of state immigration policies, and then also policies that might differentially target Latinx health. For example, overtime pay for agricultural workers. So then after we had identified the potential policies we wanted to think about, we conducted a scoping review and worked closely with policy and legal experts to identify potential pathways through which immigration policies could affect health outcomes for Latinx individuals. And then these findings informed the quantitative and qualitative analyses, which I'll talk about briefly. And also, I just wanted to flag that, so this paper was published as part of the special issue in Social Science and Medicine on structural racism and health that came out in 2018. And we submitted our abstract for the special issue and it got rejected. And I just remember at the time, you're frustrated. You're like, oh, I think this is a cool idea, but like, okay, it was rejected, fine. So let it go. And I talked to a senior mentor and she was like, no, they're not going to reject it. And to me, I didn't even know that was a thing. And so she actually recontacted the people who were running the issue and was like, this is good, like you should include it. Anyway, all that is to say, it's been one of my most cited papers. And I just say that because, in public health, like we're rejected all the time. Sometimes there's nothing you can do about it, but sometimes you can, and it's worth pushing back. So just to kind of normalize rejection and that just happens. But I also didn't know you could go back to an editor and ask. So this slide shows the conceptual pathways that we identified in our paper, and they highlight the multiple ways that immigration policy climates affect Latinx health. So the first pathway was through structural racism, so specifically fear and exclusion, and how policies, for example, omnibus policies in Arizona, which many of you remember, where there was effectively what they called, you could just arrest somebody if they looked like an immigrant, quote unquote. Another pathway is through access to social institutions, specifically higher education, and whether somebody can enroll, who is undocumented, can enroll in a state school or receive scholarships. Another pathway was through access to health-related services. So for example, health insurance policies. And then the final pathway that we identified was through access to material conditions, such as labor force participation, through policies like E-Verify and overtime pay for agricultural workers. So then these conceptual pathways provided a roadmap for us to follow when conducting the subsequent empirical research. So then given that, we started to create our quantitative policy exposure measure. And I'm going to briefly talk through that approach that we use to develop a policy climate index, and then I'll walk through each step in subsequent slides. So first, we had to choose which policies to include. And this was based on the conceptual paper I just mentioned, discussions with legal and Latinx health experts, literature reviews, and my own qualitative work. And then we determined which states had passed which policies and the specific language in the policies themselves. And so this came from our own work, and then also working again with policy experts and lawyers to make sure we correctly understood the policies. And we gathered this information from the gray literature and also like Pew Charitable Trust and the National Conference of State Legislatures. Next, we coded each policy based on how inclusionary or exclusionary it was. So this meant applying numerical codes, which were again determined based on language within the policy and consultation with legal experts. And then, there's that black page again. All right. And then we used factor analysis to see which policies covaried and should be included in the overall policy climate measure. And so this approach has not only been important for advancing my own work, but it's been really fun to work with a lot of colleagues and see how it's getting taken up in other spaces. And it's fun to be in a field of this sort of measurement of structural racism and stigma that's emerging. And so we're still very much trying to figure out the best way to categorize these policy measures, the best covariates to include. And so these are some things I'll flag later on that I would love your thoughts on. So then for this specific example, I'm going to talk through each step in more detail. So we first chose which policies to include, like I said, based on the conceptual paper and talking with policy experts. And these state level policies clustered around 4 domains, including immigration, race and ethnicity, language, and agricultural worker protections. And then I just wanted to highlight that within that, there are a lot of different subdomains. So within education, there are bilingual education mandates, whether somebody can have access to a state school or financial aid, for example. So there are a lot of policies that we ended up considering to start with. And then what we did is we took all of those policies and we coded them. So to convert them into a quantitative measure that we could then use in our exposure variable. So we wanted to incorporate as much nuance as possible and avoid creating a binary measure like much policy research had used before. So to make sure we correctly understood each policy and capture the variation, we were in frequent contact with policy and legal experts. And I wanted to show the example with the driver's license law. So you can see here that it ranged from 0, which was most supportive, to 3, which is most exclusionary. And that included sort of a blanket allowing of licenses for undocumented individuals. Or it allowed driving privilege cards or temporary licenses. So it basically looks like a license, but there's a stripe across it that says not for federal ID, or having no law one way or the other. Or the most exclusionary is explicitly having a law that prohibits it. So this is what it looked like for driver's licenses. And I'm not going to focus on this next slide. There's a lot going on. I'm just showing this to give you the sense of this is our Excel document. So for every policy, we had the domain, like I mentioned, the main domains, and then what policy it was, the description, and the coding scheme. So for those of you who do qualitative research, this will look quite similar to a code book, but basically making sure we had continuity when we were going through and reviewing all of the policies, and we could also share this with policy experts. So there was a lot of work just to create this, and then you can imagine you do this over time and just what this looks like. So we had all of those policies, it ended up being 19 policies, and we conducted an exploratory factor analysis of those, and that resulted in 1 factor, which left us with 15 of the original policies. And then we did a confirmatory factor analysis, which revealed one item with a factor loading of less than 0.5. So we dropped that and had a 14-item scale. And we then created a sum score for each state based on which policies they had enacted. And we standardized that score to create our exposure variable. So this map shows states divided into quintiles based on how strict their immigration policy climate is. So green is inclusionary and red is exclusionary. And I also wanted to flag that most maps we see represent something at the individual level. So you look at a map and you're like, oh, it's the average age of an individual in that state. But this map shows the policy climate at the state level. And I just want to highlight that in this example, we only coded 31 states because there was limited money in a pilot study. But the current research that I'll present today includes all 50 states and over time. And I'm not going to go into it here, but in this example, for this study, we use this exposure and applied it to the behavioral risk factor surveillance system, or BRFFS or BRFS, depending on what you call it. And we found that individuals in states with more exclusionary immigration policy climates had higher numbers of poor mental health days than participants in states with less exclusionary climates. And that was true for everybody, regardless of race, ethnicity. And then that association was significantly higher among Latinx versus non-Latinx individuals. So I just wanted to flag that we found those significant associations. And then given that, we moved to mixed methods data collection. So specifically, we wanted to strengthen the validity of those findings. So we interviewed 30 key stakeholders across states with different immigration policy climates. So think back to those 5 different colors on the map from green to red, and we sampled people from across states whose climates varied. And these interviews focused on how the immigration policy climate affects health for Latinx individuals more broadly, as well as variations in policy enforcement. So thinking about how some sheriffs refused to support ICE raids or how some created sanctuary cities. And in the interest of time, I'm only going to give 2 quotes today, but I'm happy to talk more about what we found. So public health policy research often focuses on how health policies affect health outcomes. And obviously this is super important and there are very strong relationships there, but the qualitative interviews that we did really highlighted how multiple aspects of the immigration policy climate affected care engagement, including access to a driver's license. So as you can see in this map, there are some states in blue that have legalized driver's licenses for undocumented immigrants, but the majority have not. And so as one individual in Alabama shared with us, if you're a clinician and you're asking your Latino patient to come in and they don't have a driver's license, they're going to drive there. You're asking them to put themselves at risk for these services. So these kinds of qualitative data, when paired with some of the quantitative measures or in general, can really help demonstrate where to allocate our energy in terms of policy reform. So similarly, I want you to think back to the conceptual pathways I described in the beginning of the talk, specifically how immigration policies are a form of structural racism that can create a climate of fear. And these climates of fear can constrict many aspects of individuals' lives, including their ability to exercise, attend children's school-related events, and access health services. So as an individual in North Carolina shared, people are terrified about accessing school health services, hanging out in the park, walking their kids to school, and generally being seen. People drive to work, but everything else is a luxury. So again, this quote also highlights the role that driver's licenses may play in all aspects of individuals' health. And so I wanted to keep that in mind when I moved into the quantitative data that I'll present today. So based on that, the next steps that we wanted to do were to create more longitudinal exposure measures, and then to compare the overall climate. So the overall policy climate, those 14 policies that I mentioned, as well as subdomains and individual policies. So the current project that I'm going to turn to now is focused on state level immigration policies from 2013 to 2019 and their effect on birth outcomes among Latinx individuals. And this project expands the work I just mentioned by exploring the impact longitudinally. And then, like I mentioned, we're also going to look at subdomains as well as individual policies. And so lastly, one of the things that we're interested in looking at is not just the policy climate overall, but really how inclusive or how exclusive a state is and how much that matters. So really thinking about magnitude. And like I mentioned at the beginning, the data that I'm going to be presenting right now are, hot off the press, as it were. And so we're really still interrogating what we found and thinking about how to improve or to think through more like our exposure and which is the best exposure to use. And so I'm going to present some different examples of what happens when we use different exposures and to show sort of some of the issues that we're grappling with in this type of research focusing on policy climates more broadly. So why immigration policies and prenatal care? Why does that matter? So nearly 25% of infants in the US have a foreign-born birthing parent, and about 13% of the US population is foreign-born. So these are pretty large numbers and affect a large percent of the population. And of these individuals who are foreign-born, nearly a quarter are undocumented. And this renders them ineligible for federal assistance, including Medicaid. And this is particularly important because this lack of insurance coverage always has huge implications, especially on people who are pregnant. And it is also important that in terms of proof of concept for the work that we're doing, other research has shown that there is a direct impact of immigration policies and the immigration climate more broadly that happened around Trump's election and on preterm birth. So given that people have seen that data, we wanted to look explicitly at shifts in policies by year over time. And also just in general, we've seen that policies are an important driver of prenatal care uptake, but most of that work has looked at the impact of a single policy on a single outcome. And so we're expanding that by thinking about the policy climate more broadly. So to give you a sense of when I say policy climate, what that looks like, I wanted to start just by giving you a sense of the variation in immigration policy climates across states. So this is just another way of showing what I presented to you in the map that I showed earlier in the talk. So what's going on here? You see the states on the x-axis, and on the y-axis, it's if you take the sum of the codes, right? So you think about, like we said, certain policies. In this instance, if there was an exclusionary policy, it was a -1. If there was no policy either way, it was a 0. Then if a state had an inclusionary policy, it was a 1. So the blue here is inclusionary. And so if you look to the left, states like Alabama, Georgia, Indiana have passed a lot of exclusionary policies. And as you move to the right, you'll see states like Washington, Oregon, and California that are quite inclusionary. But what I want you to take away from this more broadly is that there is quite a variation in states overall in how exclusionary and how inclusionary they are, which allows us the variation to do this kind of work. So like I mentioned, there are 14 policies and the exposure could range from -1 to 1 for any given policy. So overall, this means the range that we're using is -14 to 14. Though in reality, as you could see in that last slide, it's actually about 10 to -10. So that's about what we're working with. So in terms of the methods, the data source that we use was from the National Vital Statistics System, so their birth records. And we had the restricted use natality files, so we knew what state people lived in. So the study population were US residents with singleton births and with known gestational age. And so we had about 23 million of these records, which is somebody who usually uses data sets like the National Survey of Drug Use and Health, which is collected annually with 60,000 people, to be able to have an N of 23 million is just, it's crazy, but it's amazing because it allows us to look at intersectionality in ways that we're often not powered to do. So the exposure was the Immigration Policy Climate Index score. And like I mentioned, I had worked on this originally as a cross-sectional analysis, and then Dr. Goleen Samari collected the data over time. So that's the version that we're using for this. And the exposure was the score in a given state 6 months prior to conception. So the reason we did that is because we wanted to think about what is the policy climate a person is living in as they're deciding to or as they're becoming pregnant, and then during the pregnancy. So that's why we picked time prior to conception versus just from the moment of conception. And so like I mentioned, the index had 14 policies, the range of scores for each policy, the options were -1 to 1. And then the reference date was the baby's date of birth minus gestational age minus 6 months in order to get to the 6 months prior to conception. And then our outcome was the adequacy of prenatal care utilization index, which has been used across multiple other studies and is well validated and can be generated from the birth record data. So we started by doing a descriptive analysis. So really thinking about distribution trends in both the state policy climate and the adequacy of prenatal care utilization, and then also characteristics of pregnant people by state policy climate. And I'll show some of that in a moment. And then given that prenatal care usage is a common outcome, we used log binomial regressions to estimate risk ratios rather than logistic regression, which would have produced odds ratios. So we use these relative risk regressions of the association between living in an exclusionary state and receiving inadequate prenatal care. And then all the models used a Poisson distribution, log link, and robust standard errors. And then the covariates that we used were state fixed effects, year of birth, parity, age of pregnant person, educational attainment, which we had as college or not. And I'm happy to talk about this. We've had a lot of discussions around which covariates to use, which are mediators, which are not, which maybe, trying to make sure we get around confounding. So this is something that we've had a lot of debate around. So I want to show, I know there are a lot of numbers going on, but what I want to just highlight here is that the state immigration policy climate was assigned to pregnant individuals, like I mentioned, 6 months prior to conception. And so these descriptive statistics summarize the data for all births from 2014 to 2019. And in this table, we classified states based on the tertiles of the annual score. So this means that states with a score of -3 or less were exclusionary, -3 to 2 were neutral, and then greater than 2 was inclusionary. And I'm not going to show all the demographic characteristics, but I wanted to focus on just a few things. So first, if you look at foreign-born Latinx and US-born Latinx individuals, they're much more likely to live in states with exclusionary policy climates than exclusionary. So you can see on that top line, almost 16% of those individuals lived in inclusionary states, right, versus exclusionary. Same for US-born. These are row totals, just to flag that. And obviously, while individuals don't have total agency given structural constraints, they have some control over where they live. And individuals who are Latinx tend to live in more inclusionary or at least neutral states. And this is also likely due to historical migration and settlement patterns. Obviously, the fact California, New Mexico, Arizona, Texas are part of Mexico for so long, there are a lot of historical trends going on, but I do want to flag this. And then also to notice that there are some differences in the level of prenatal care adequacy by whether or not a state is inclusionary versus exclusionary, which was interesting to see, and then allows us as part of this to test whether or not the state immigration policy climate has an effect on this. So I wanted to start by showing a couple of figures. So this shows the annual trends in average immigration policy climate across states based on resident of the pregnant person. So this is not by whether or not a state is inclusionary or exclusionary, it's simply the overall score over time. So you can see, and this is all within a point of 1, so basically a shift in one policy. So the changes are not huge, but you can see it was getting a little bit more inclusionary, or at least toward neutral, and then dropped again after 2016, 2017. And this is overall. And then you'll actually see similar patterns on the right, which divides by individuals who are Latinx versus non-Latinx white. And I do want to note, if you look at the blue line on top, individuals who are Latinx are living in states that are more inclusionary, which matches what I just mentioned in the demographic table. So again, the patterns look similar, but there is a division of how inclusionary or exclusionary the state is based on ethnicity. So the other thing I wanted to do is to show you, this is the same that you saw before, except divided by US versus foreign born. And so you see that there are more differences between US-born Latinx and US-born white individuals in terms of how inclusionary or exclusionary the overall state immigration policy climate is versus those who are foreign-born. So it was interesting to see this descriptively because we actually haven't really seen this data out there. And so we're debating if we can turn this into a separate paper just to really show where people are and the climates they're living in. And then, because it is interesting to see some of these differences. So what this shows is the annual trends in the proportion of pregnant people by adequacy of prenatal care utilization. And that's measured as adequate plus, adequate, intermediate, inadequate, or missing. And as you can see, most people, so 37, 38% are getting adequate care or adequate plus. But the percent of those with inadequate or even intermediate care is still relatively significant. I also just want to flag for those of you who work on birth outcomes, getting adequate plus care doesn't always necessarily just mean you're getting the best care possible. It might mean that it's a high-risk pregnancy, so people are quite highly engaged. So that's something to think about that I wanted to flag here. So similarly to the way that I presented the data on the policy climate, I wanted to divide this here by ethnicity. So you can actually see some differences here, just eyeballing it between prenatal care utilization among individuals who are white versus Latinx among US born individuals. So you can see that the level, like in kind of a yellow-green color, inadequate care is higher among US born Latinx versus US born white. And then we see similar patterns when we compare foreign born Latinx individuals to foreign born white individuals. So again, the inadequate care is higher. And it's a little bit higher to eyeball, but you can also see if you're looking at the two squares on the right, US versus foreign-born Latinx individuals, that foreign-born Latinx individuals have higher levels of inadequate prenatal care. So to flag that. All right, so given that background, I wanted to present some of our findings. So what this is showing you is the risk of or the relationship between the overall state immigration policy climate and inadequate prenatal care. So the second column, the overall risk ratio, is looking at the association for everybody. And then foreign-born versus US-born individuals, regardless of race, ethnicity, for Latinx versus white individuals, regardless of nativity, and then foreign-born versus US-born Latinx individuals. So let me just talk through this briefly. So the findings overall, the overall risk ratio, suggests that individuals living in an exclusionary state are less likely to have inadequate care than those in an inclusionary state. So this was surprising to us because we figured if you're living in an exclusionary state, regardless, because of potential spillover effects, that you might have higher levels of inadequate care. However, this is a snapshot of everybody, most of whom are US born white. So maybe we're not seeing a spillover and then they're driving this effect. However, when we start exploring differences by ethnicity and nativity, the picture starts to become clear. So for example, we can see that the risk of inadequate care is higher for foreign-born versus US-born individuals in exclusionary states, or put another way, the effect of living in an exclusionary state on the risk of inadequate prenatal care matters more for foreign-born versus US individuals. And then we see the same pattern for individuals who are who are Latinx versus white. And then the risk of inadequate care is higher for foreign-born Latinx individuals versus US-born Latinx individuals in exclusionary states. So then the next step, so that's the overall state climate. The next step, we conducted similar analyses, but changed our exposure to the subdomain of health policies, of the health policy climate. So that consisted of 4 policies that regulate access to healthcare. And while the overall risk ratio flipped compared to the overall policy index exposure, we weren't completely surprised because this is focusing on health-specific policies. So that suggests that for everybody, expanding access to health insurance is going to give them better access to care. Otherwise, the findings are quite similar across. So we're still seeing associations where individuals who, for example, are foreign-born versus US-born are more likely to have inadequate care in exclusionary states than those who are US-born. So then lastly, we drilled down to look at the outcome of a specific policy that we thought might most affect prenatal care. Namely, does the state provide health insurance to pregnant undocumented people? So interestingly, there was no effect overall, which highlights the need to drill down to look at subpopulations and also to think about the policy climate as a whole. And then as you can see from there, we found similar patterns. For example, the risk of inadequate care is higher for Latinx versus white individuals in states that do not provide health insurance for pregnant undocumented people. So the next thing that I wanted to show you, those are all focused on health, on sort of the overall climate and then the health subdomain and then a specific policy. But given the work, I wanted to turn to a sub-analysis that we did based on the qualitative findings that I had reported earlier, specifically the importance of driver's licenses. So again, this is what the top table is just what I just showed you. It's the singular policy. Does a state provide health insurance for pregnant undocumented people? Yes or no? And then below that is the association between prenatal care utilization and living in a state that provides driver's licenses for undocumented individuals. So as you can see, overall, people in states where undocumented people cannot have a driver's license are less likely to have inadequate prenatal care. But again, when you look at subgroups, we see similar patterns that we did before, meaning if an individual is foreign-born versus US-born, they're more likely to have inadequate care in exclusionary states, same for Latinx versus white, and foreign-born Latinx versus US-born Latinx. One thing I just wanted to flag is that we see associations that are actually statistically different and stronger among, if we look at the association between the driver's license policy than the health insurance policy. And I know these are not huge differences. I mean, I understand that. But the point is less about the strength of the associations, but more about the need to loop back to think about this health in all policies framework and make sure that we conduct mixed methods work to think about how other policies may be driving our findings, and also what that means for where we put our energy for intervention. So for example, normally if we're thinking about a health outcome, we may initially look at a health policy, either one policy, or even look at a health policy subdomain, but perhaps there are other policies like the driver's licenses that are also driving this. So what I wanted to turn to now is to shift to bring up those points for discussion that I've mentioned as we move toward the final part of this presentation. So I'm going to talk about the exposure that we used, and then I'd love to hear your thoughts about how we might best approach this or what makes sense for policy translation. So the data that I just showed you used tertiles as the exposure. So we created those tertiles, and then we created a dichotomous variable as the exposure. And that included the neutral category. So that meant that scores of less than 2 were categorized as exclusionary, and those of greater than or equal to 2 were categorized as inclusionary. However, if we categorize by sign, that means scores of less than or equal to 0 are exclusionary, scores of 1 or greater are inclusionary, or we could also use a continuous policy measure. So that's one thing I'll walk you through. And then the other thing, like I mentioned, that we've been debating was which covariates to include, also to make sure which are not confounders, and then whether and how to include state level controls. So just briefly to give a few examples of this, I'm just going to show you the findings that you already saw. So these are the ones I already presented, looking at the overall state policy climate using tertiles. So where a score of less than 2 is exclusionary. And then if this is the findings, if we look at the relationship where we base it on sign, not tertiles. So saying everything that is less than 0. And what I just wanted to highlight actually that's interesting is you see the overall risk ratio flip. So we do actually see differences in how we categorize this. And also, again, while not hugely different, there is a statistically significant difference then between the magnitude of the association. So I'm just showing you this because I want to give you a sense of some of the questions that we're thinking through and what it means to categorize these exposure and how that impacts our outcomes. So we then ran the numbers to see what would happen if we looked at a 1-unit increase in the policy climate score. So not by tertiles, not these huge jumps, just a 1-unit increase. So moving from -1 to 0, say. And as you can see, again, we're seeing that overall risk ratio flop back to positive, which was different than, or greater than 1, which was different than what we saw when we looked at it overall from the tertiles. We also see that everything else is also less than 1. So while our relationships before using tertiles were all above 1, none of these are. So then we thought, okay, maybe it's because it doesn't matter overall, but it's whether you're in exclusionary and getting more inclusionary, or less exclusionary, I should say, or an inclusionary and getting more inclusionary. So then we stratified by that, and so looked at a 1-unit increase in inclusivity among exclusionary states or inclusionary states. And I mean, you can argue like, yes, there were some differences. You can see this. The confidence intervals don't overlap, but we're talking about 1/1000th, right? Which arguably is we're only seeing because we have so many people. So it was interesting to see that that really didn't matter at all. But I'm showing you this to give you a sense of when we're doing this, how carefully we're thinking about the exposure and how some little shifts in the way we categorize things can affect the types of outcomes that we get. So briefly in sum, we found significant associations between the overall immigration policy climate, the health policy climate, and insurance access policy and the receipt of inadequate prenatal care. We also actually found the strongest association between driver's licenses and prenatal care. And then, as I mentioned, the conceptualization of the policy climate exposure mattered. So thinking about tertile versus sign or continuous measure. One thing too, which I didn't go into detail here, but we ran in terms of sensitivity analyses with and without the covariates, and the association strengthened when we added covariates, particularly education levels. So we're debating whether or not we should keep that in the model. So briefly to summarize, I want to wrap up by highlighting the advantages of using this policy climate approach as an exposure. So first, it's a robust measure of the likelihood that certain policies exist in the same form at the same time in a given state. And this approach can comprehensively capture a broader measure of structural level exposures in a way that a single policy approach cannot. Also, it allows us to statistically justify including various types of measures into the exposure. So policies, practices, attitudes, funding streams, versus simply using them as control variables. Also, we can test for validity by looking at how states rank within a policy climate measure and then comparing this to other exposures that should have similar impacts. So for example, state attitudes towards immigrants. And then also too, this approach doesn't eliminate our ability to look at the impact of a single policy, which we obviously all agree is important. What it means is we can look at that and more, including the overall policy climate and subdomains. So looping back to our points for discussion, one of the things we're still thinking through is how to conceptualize the exposure, like I mentioned. And one thing I want to highlight is we were starting to fiddle around with, okay, why are we seeing this shift between this when we use sign or when we use tertiles? And one is that there are 11 states that flip from inclusionary to exclusionary when we use tertiles versus sign. And these 11 states all have an overall score of 1. So they're weakly inclusionary when we flip them. So that's one thing. So we can see exactly which states flip and start to think about how that matters. Also, even that though, thinking of, okay, all these states have a 1, that really obscures differences among states with a score of 1. So we have New Jersey, which provides all the health benefit measures we mentioned, but not driver's licenses. And then Oklahoma, which basically has a 0 for 7 policies. So they're basically becoming a 1 through primarily being having inaction around everything, versus New Jersey that is actually creating policies. So what we're thinking about doing next is creating a count of whether or not states have how many inclusionary versus exclusionary policies to think about action specifically versus not just kind of defaulting to 0 because we're getting a wash between inclusionary policies or states not doing anything. So next steps generally with this work is to really think about incorporating additional policy climate measures to try to get at structural intersectionality. So thinking about structural stigma, sexism, racism, things like that. And this aligns with other work I've done that I'm happy to talk about where we created a measure of structural heteropatriarchy with structural sexism, structural stigma, and LGBT stigma, and preterm birth outcomes. And then the other thing is to think about if there's a way to trace people longitudinally within a state as that state policy climate shifts. So for example, as California were to get more inclusive, what does that mean for an individual living within the state? So this is obviously a little bit of a ways off, but we're really excited to think about that sort of structural intersectionality more broadly. And I just want to end by thanking my co-authors on these multiple papers, the funding mechanism that I have, and then the people who took the time to speak with us, particularly during the qualitative interviews, and to thanks all of you for coming.
So thank you, Morgan, for a great presentation. So just a friendly reminder that if you have questions for Morgan, please put them in the Q&A. We already have some filling up. So Morgan, sometimes it's easier if you just read them yourself and then answer them, because I mean, I can bring it up too, but yeah, so.
Yeah, I can do that. So the sample size of the survey, so they're birth records. So it's not a survey per se. They're things that are filled out by the clinician. So some of the things that are in the birth records are, done at birth. So we know gestational age, we know they're called from the medical records. And then prenatal care was determined by the birth records as well of when people came in. So that's where that is. For the Q&A, okay, sample size and surveys. Okay, how might these policies impact immigrants of other races? Yeah, exactly. So that's one of the things that we're interested in doing in the next iteration, is thinking about incorporating race ethnicity into the paper. And we actually, I mean, I'm happy to show you, we have those analyses separately. I didn't present them today in the interest of time, but we wanted to focus specifically on Latinx individuals, obviously acknowledging that that's an ethnicity, not a race. And so the next paper that we're doing is we're particularly interested in thinking about the intersection of race and ethnicity more broadly, and thinking about Middle Eastern immigrants, for example, which is an interest particular of Dr. Samari, who's also on this paper. So it's something that we're kind of working on this side as a second paper.
So I'll just jump in while people are thinking of questions to ask. One question I had was, what about year of arrival? Like, it seems like your exposure to the different policies is really going to depend on how long you've been in the US, right? Because you can always adjust and figure things out as you go along. So can you talk a little bit more about that?
Yeah, no, I'm so glad you brought that up, because it goes back to the major limitation of all the work that we do, which is we are bounded by what people get asked and what data we have. And so we don't know. And it's been so hard to find data sets that ask even about nativity. So we're lucky that the birth records have that much. But yeah, I mean, we just don't know for this example. And so that's something that it's such a blunt measure to say US versus foreign born. Somebody could be foreign born and move here when, they're 2 months old. And so we also don't know documentation status. And that's been something that we've only found. I mean, I know in the California Health Interview Survey, there's some proxy ways to assess it. PATH, which actually is a data set focused on tobacco, has asked the question, but it's really hard to find data sets that do. And I think that's something, and this is sort of my own soapbox, which I'll quickly get off of, but I honestly think some of the questions that we ask are or don't ask is there's some intentionality in the types of erasure that we have. I mean, I think there's a reason the National Survey on Drug Use and Health didn't ask about sexual identity until 2015. Neither did the National Level Youth Risk Behavior Surveillance Survey, because if we don't count the inequalities, we can't say that they're there. So I think that's something that is a huge issue. And I wish I had an answer for you other than we're trying, but we just don't have the data. Sarah, do you have your hand up?
I also have a question in the chat. I think it's a good.
Okay. Call or comment energy simulation. Yeah. So, that is actually something that, I've been working on in the qual work. We're trying to find ways to do it quantitatively. So for example, by proxying out number of ICE raids, it's not perfect, but to answer your question, yeah, we saw a huge amount of heterogeneity. For example, the sheriff in Salt Lake City just refused to implement any of, which obviously Utah is a more conservative state, refused to implement any of the exclusionary policies. It was basically just like, nah, we're ignoring it. And I think that's something that is a huge challenge with state level policy research is statistically, we have to almost assume that all policies are implemented equally and enforced equally, and they're just not. One of the things I forgot to mention that we did is I keep using the term policy, but we also looked at executive order, judicial action. So basically, if there was another way of getting to the same outcome around, say, access to driver's licenses or health insurance, we included that because we were much more interested in what was happening sort of on the ground versus how it got there. But yeah, I think that's one of the main reasons to include mixed methods research is to really see where those differences are. So I appreciate that. How do you think about other state policies that may spill over into your outcome? So for example, abortion policies. Yeah, that's a really good point. And it's something we have gone back and forth about. We kind of struggle in policy analysis. I was actually talking with a couple of colleagues about this earlier this week of how much can you put into your model, because you can sort of make the argument of like, everything can have an effect. And then we kind of joked, we're like, okay, you can't have this kitchen sink approach, but like, for a lot of this, I'm sure structural sexism matters. I'm sure structural racism matters. I think your point about family planning policies are very well taken. And so thinking about how to do it. And so I think I like your idea of a state level covariate, and I'll talk with some of the co-authors and think about how we might be able to do that. Okay, so the question about other population health indicators, such as mortality, which would include men and women. Meaning as a correlate or as a covariate, we can definitely think about that. I'll just have to think for a second about where we would pull that from. Normally when we normally when we pull state level covariates, we think about usually they come from the census or the American Community Survey, and so I'll have to check and see what's there. But thank you. And then Erika, who is a former student who just made the comment. So I actually sponsored her thesis. God, when was this? Like 4 or 5 years ago. Now she's doing her PhD, which I love. So her question is about deciding which policies to include and how to deal when policies are passed versus when they were implemented. Yeah, that is a huge question. And so we have been playing around with the passage date, the implementation date, whether sometimes if there's funding behind it. For example, when we're looking, and this is slightly different, but with cannabis policies, we're looking not just at passage versus enactment, but we're looking at when the first dispensaries came online, because if you argue, okay, you have medical cannabis, but you don't have any dispensaries, you don't actually have availability. And so at the risk of creating a paper with like 35 pages of sensitivity analyses, which is basically where we're going with this one. Your point is very well taken, because there are a number of states. I think the most egregious was Maryland, where it was like a 10-year lag in the cannabis policies between passage and enactment. So a lot of analyses have sort of falsely categorized them, as it were. But yeah, I tend to go, so sorry, short version of that, I tend to go with enactment. If it is a policy, so it's two things. It's enactment if it's like a policy about access to something, so substance use. If it is about creating a culture of exclusion, I go with passage, because I would argue that a lot of the narrative around, say, omnibus policies or policies about marriage equality shape the environment within which people live in debates around their passage as much as the enactment itself. So that's sort of how I've divided it based on the work that I've done. But I'm happy to talk more about that offline.
I have a question for you about selectivity, and probably you have a good answer given that you do work on abortion too, but or I guess I know you don't do work on, you're doing it on cannabis production, but I'm thinking about the possibility that people might move to other states to have births, right? That's a classic. Yeah. Because someplace else is more generous, for maybe even for indigent folks. But I just was wondering how you think about that, because certainly in the migration literature that there are patterns of we know that there are networks that bring people to certain places, particular destinations. The other comment I wanted to make is Jennifer Caris Montes and her colleague here at UW, Jake Grombach, have this policy level data set that you might consider at this. I think it's at the state level, but they've used it quite effectively to look at mortality related deaths, and particularly around opioid and other kinds of mortalities.
Thank you. Yeah, her work has been so helpful, both actually, I mean, in general for how I think about this, and also how I respond to reviewers when they're like, do state policies matter? And I was like, yes, see Montez et al. Like, of really think, because it's true. I mean, I think people have made the argument of do local, like the sort of proximity of policies, right? Do local policies matter more? Which I think, we can talk about that. And we particularly around immigration, this sort of, blue dot red state and what that means. But yeah, so thank you for bringing up the question around state. And we actually, I should clarify, we don't know from the birth records, we know state of birth. We don't know where they live. And so there is a possibility that someone is living in, I'm trying to think of examples where, maybe that border states are quite different. I guess probably where you are, right? You go east. So you go Idaho versus Washington, Oregon versus, the Dakotas, Montana. And so that may be something, and that's something that we just don't know from these data of where they live. Although I think I'd have to think about what the argument would be of if then access to prenatal care is governed by the state that they can travel to get care, or if it is governed by the state that they live in that they had to leave. Obviously, it is harder to get care if you have to drive somewhere, particularly if you don't have access to a driver's license. And that's actually something I'll have to think about how to flesh out in some of the qualitative work, because that sort of cross-border spillover piece is something that's come up in the substance use work that I've done on policies. Mm-hmm. Yeah, thank you for bringing that up. Any other questions? If not, also feel free to email me. I can put my email in the chat. Because I wanted to frame the talk this way to show you that, you read the papers and everything seems like so tight and smooth and clear, but behind the back, in the background, there are all these things that we are trying to figure out, particularly as we're trying to measure something as complicated as the policy climate, and we're beholden to the data that we have access to. And so there are always going to be limitations to the work that we do, and we think about it and control for it the best we can. But it's why I'm really excited, to see this field expanding and really moving forward in terms of just the data coming out and the measurement specifically.
I think you might have been, yes, don't forget there's a session that to meet with Morgan is at 2 p.m. But in between now and then there's a T32 info session. you're welcome to come too. So I wanted to ask you, Morgan, it seemed like you were suggesting that this was something you're going to do, and I think you could have a theoretical frame reason to do this, but to have separate estimates for inclusionary and separate estimates for a range of inclusionary versus exclusionary policies, because the one could mediate the other, moderate the other, and that might be important. Is that?
Yes. Yeah. Because we were trying to think about, it's how inclusionary, does it matter if you switch from exclusionary to inclusionary? Like, is there a tipping point? Is it a 3-point change? So we're trying to think about, based on some of the theoretical work that has been done, what makes the most sense to do. And sort of what we're feeling is that there is something quite different between moving from, say, a 2 to a 5 on inclusionary versus a -5 to a -2. Like, that actually feels quite different. But then also, more importantly, trying to figure out how does it, like, how much it matters which policy gets changed, right? So for example, if somebody is not having anything to do with education, maybe it matters less if somebody who's undocumented has access to state funds for a scholarship than it does around health insurance or a driver's license.
Yeah, so substantive as well.
Yeah.
But I think it's plausible. I mean, we all know there's all sorts of contradictory policy. The policy landscape is very contradictory and sometimes works at odds with itself.
Yeah.
We don't generate totally coherent, rational policy landscapes. So.
No, there's definitely a lot of, and just going back to like the spillover effect, it's when, if we only sort of measure the policy that has the most direct tie, I think abortion policy is the best example of that. Like, does anybody really care how wide, like the hallway is in a clinic? Like, no, that is completely about restricting abortion. That has nothing to do with care, right? So there are policies whose spillover effects are actually the main reason they're being passed.
Mm-hmm. Yeah.
So that's been something, to see. That I've been learning a lot, and also trying to think about the link, and this is a whole other issue, but like, the link between our research and advocacy, and sort of what we as academics can do beyond simply publishing this and moving on, and how do we work with advocates who obviously know how to do this better than we do, because this is what they do, but trying to actually enact change, particularly in this space. This is sort of where my heart is, versus just sort of publishing it and being done with it.
Yeah. I know Jennifer's thought a lot about that. You should, if you'd like, I can introduce you to her.
Yeah, that would be great.
If you don't know her already.
Yeah.
I mean, I remember her when she came to talk 2 years ago. She talked about how they had looked at gun policy legislation and its impact, gun and alcohol and abortion policy. And they were reluctant to report all their findings just because, especially around gun legislation. Yeah. Which was an interesting, challenge, interesting debate.
Yeah, it is. Getting the politics involved becomes so challenging around some of this, which, I can definitely, I'm happy to talk more about how that has come up in some of the immigration work too, of like, oh, you're showing that improves care. Well, why should we want to improve care? That sort of narrative. Like,
right.
Okay.
Exactly. Okay, well, don't forget, everybody, you've got a T32 of those students, and then maybe Jess, you could drop the 2 p.m. thing in the box. But
great. Thank you so much for all of you.
Same message.
So much, Morgan.
Oh, thank you. Thank you.
Yeah, and join us next week for Juanita's talk.
Yes.
Presenting.
Yes,
Yeah.
next week.
Yeah, sorry. Forgot who was presenting. Thank you, everyone. Thank you, Morgan, for giving a fantastic talk. And join us next week, same time, same place.
Great. Thanks. Have a great week.